E obrigado, Paulo Marcos, pelas palavras. A gente vai começar aqui a primeira palestra, Novos Modelos Assistenciais e seus impactos na cadeia da saúde suplementar. Para isso, a gente vai convidar o Dr. Frederic Goldstein, fundador e presidente da Accountable Health and CEO da Population Health Alliance, a PHA. Só para contar uma breve história para vocês, em 2000, mais ou menos, 2002, a gente foi para os Estados Unidos e a gente teve contato com a DMA. Quem já ouviu falar em DMA? Quem já ouviu falar em DMI? Quem já ouviu falar em CCA? E agora está ouvindo falar em PHA? Não é tudo a mesma coisa, porque não é tudo a mesma coisa, mas assim, está tudo relacionado. Então, por favor, é só para vocês entenderem que são muitas siglas, mas elas estão relacionadas. E o Dr. Frederic vai ter 30 minutos para fazer uma exposição. Por favor, Dr. Frederic. Dr. Frederic Goldstein é um dos grandes conferencistas mundiais sobre gestão de saúde populacional, é mestre em administração e saúde, com cerca de 30 anos de experiência. Já participou de debates em câmaras legislativas norte-americanas para mudança na legislação sobre saúde e assistência médica. E atualmente é o CEO da Population Health Alliance.
Thank you very much. It's a pleasure to be here. Turn that off so I don't hear myself again. First of all, I want to congratulate you, Paulo, and ASAP, and the board, Cadeia. What an incredible event. Bringing together this many people here is fantastic, and you should be congratulated. So, thank you. And Lisa, thank you so much for the invitation and for sponsoring me down here. I really appreciate it. It's great to be here. This is my 4th year. For those of you who know me, I tend to dress conservatively. I wear red tie, the cufflinks, and today I wear these. So, people wonder what's up with the pink socks. So I tell you a little story because this is about why you are here. So, a gentleman named Nick Reed, who works in the United States, was in the technology healthcare industry, and he went to an event called Burning Man. And Burning Man is in the desert in Nevada, and it draws tens of thousands of people, and it's a wild event. And you have artists and thinkers and IT people, and it's a week of experiencing this craziness. And Nick went to this event, and some of the focus of the event is radical inclusion. Everybody can be involved. Collaboration and community and gifting are 3 of the 10 principles of this week-long event. And it changed Nick, and Nick went and left the IT company he was at, moved out to Portland, Oregon, and went to another company that does telemedicine. And Nick took those principles and said, you know, I have a friend of mine who has a sock company here, and I'm going to help them by wearing their socks. And I have another company that has a kilt, and he wears kilts now. Kilts and pink socks. And he went to the event in one of the big healthcare conferences in the United States, and he was wearing these pink socks, and he had brought pink socks with him to gift. And he gifted his first set of pink socks to Eric Topol. And Eric Topol is the cardiologist from the Cleveland Clinic. And Eric Topol took the socks, they took a picture with Nick, they put it on the internet, on Twitter, and it went viral. And everybody started asking about the pink socks. What's up with the pink socks? And it was at the big health information conference. And Nick gave them away to get people to begin to think about collaboration and how you work together to transform the healthcare system. And a friend of mine, Greg Masters, said, well, they're pink, real men wear pink, and they have mustaches, and Movember is the national month for men and cancer and getting screened for prostate cancer. So it's about transforming the healthcare system from the bottom up. And now over 1,000 people have been given pink socks. Farzad Mostashari, David Nash, leaders of the healthcare system in the United States, and they wear them to the conference. We are trying to transform healthcare from the bottom up. And this is the first time pink socks have shown up in Brazil. Hopefully we get more pink socks here, and next time I come, I'll be sure to bring some and hand them out to you as you try to transform your healthcare system here. But if you go on Twitter and you search pink socks with the hashtag pink socks, you will find an ongoing Twitter feed about people transforming healthcare and wearing their pink socks at all of these events. And if you go to the Eli Lilly site, you will find a blog about pink socks and the transformation of healthcare. And I challenge all of you today, as you look at creating sustainable healthcare systems, each of you in your own way is working to transform healthcare. And that is a great mission. So with that, let me get on to the formal presentation and talk a little bit about what are the problems we're facing. And my apologies, obviously I should be speaking Portuguese here. I tried a little bit, Duolingo, I didn't practice enough, and my apologies. What is sustainable health? What is the system? What are the touch points? Where can we create this, and what do we need to change? Who's responsible for it? And then some examples in the U.S. So we know the problems. I think Paulo Marcos said we're not going to focus on cost, but we need to talk a little bit about cost. It's a problem. We have a quality problem, and we know that whether in the United States or Brazil or elsewhere, we are all facing an aging population. There's a global shortage of healthcare workers. There's a rise in non-communicable diseases. I think it was just reported obesity is now more than half the people in the world are overweight, and by 2025, 25% will be obese. So we're facing that. And finally, what's going on, in the U.S. and Brazil? We know there are different problems. So you've seen charts like this. This is the United States, and the line is hard to see here. But all countries are experiencing growth. OECD countries, the United States, and obviously we always manage to ring the bell. We spend more than anybody, and we grow more than anybody. And so this is what it sort of looks like. Some of you have seen this graph, and I just wanted to point out where the United States is and Brazil. And some of the interesting features to think about here are that you have a public-private system that in many ways is close to the United States versus some of the other developed countries that have a much larger public role in spending. And so we do have some ideas in the U.S., and we talked about some of these yesterday with ACOs, but they're just ideas. Your system needs to create its own unique models and ways to solve things and take ideas that work for you and adjust them and throw out ideas that don't. These stats just give you a sense. We have 312 million. This was in 2013 by the World Bank, and we have $16 trillion in our GDP and spend about $3 billion on healthcare, and it just keeps going up. And your population at 197 million, with about 185 billion in your healthcare spend. You're seeing continued growth in your population and continued growth in your healthcare costs, just like everybody else. So it's become a problem, and this idea of sustainability is now a national discussion and an international discussion. I'm going to go through this chart. It's a little bit busy, and a few of them are busy, and I may read some of it for you, for those that maybe can't read this English as well. But you do have differences between the high-income countries on this side and the developing countries on this side, but they're all facing this issue of rising costs. Why? In the developing countries, it's because we have this increase in usage, we have increase in technology, we've got this big demand. In the developing countries, it's because maybe it was low spending to start, and they're just ramping up that healthcare system and trying to begin to provide appropriate services to their citizens. You have issues with access and choice. So what does the consumer expect? In the United States, they expect to walk in, get treated right now, and if I want an MRI, I want my MRI and I'm getting it. And they just walk in and expect it, and doctors often will just say, well, I don't want an unhappy patient, I'm going to go ahead and order that. In the developing countries, you've got a differential issue of access between the wealthy and those who maybe have less. You have rising expectations in the U.S., as well as unaffordable drug prices. And that is also one of the problems we're now seeing in the United States with some of the new drugs like hepatitis C drugs that are extremely expensive. In the United States, in the 90s, we put in managed care. It bent the trend. The problem was people didn't like it, and they threw it out and said, we're not going to allow you to tell me this is my doctor. I want to go see that doctor, whether the doctor's of any quality or not. So individuals pushed out what sometimes are some reforms that make sense. Right now there's an ongoing argument with narrow networks. Do we have a narrow network of providers that you can see, and that network is not always built on cost? Oftentimes it's for quality. We want you to go see Dr. X or this hospital because they're better, but the citizens say, but that's not my doctor. I want to see the other one regardless of their quality. So we have citizen objections. In the developing countries, we have urban elites who are trying to protect interests. And then obviously the power of the profession to push this through. So all countries are facing varying degrees of issues with their system and challenges. This one is also very busy, but let me go to just a few points. They're projecting, the OECD is projecting healthcare costs, let me just move over here so this pointer doesn't work, to continue to grow 14% here in 2060 if nothing is done. So while we've had this slowing, it's now going to pick back up. And we know that it's driven by technology and rising income and also this aging population. We're facing all of these issues at once. And if you look in the lower right, they talk about some of the levers. So there's a supply side lever. We can change how we pay doctors and providers and hospitals and others. We can create competition. There are demand side issues. And this one is interesting because they talk about gatekeeping in the preferred drug list and sharing of costs. But I look at demand side much broader. And that demand side is, what am I doing every day about my health? What are the citizens doing every day about their health? Yesterday I was walking from the hotel to a mall, and right there on the street of here in Sao Paulo, I saw one of these big signs with an exercise set up right there on the street. And I took a quick picture of that, put it up on Twitter, and said, hey, look what they're doing in Sao Paulo to get people out and exercising. So demand side also includes what we all do about our health, and we need to educate our populations better and our citizens better so they understand their role in improving health. You have the whole public side and the management coordination where they can control pricing or control utilization or assist healthcare. And then finally, the revenue side. So this is from the National Health Service in the United Kingdom. Sustainable healthcare, their definition, healthcare that meets the needs of the present without compromising the ability of others in the future or elsewhere now to meet their own needs. I thought this was a little interesting because what if the two don't match? What if to meet the needs of today, we can't meet the needs of the future because we got to spend it now? So we need to look at this and say, how do we create that balance and what is that balance in our system? The Canadians look at it this way. They've created this beautiful chart that talks about the bases: accountability for results, fair and timely access, that we get value for the money that we spend on our health care, and that our health care is appropriate. And then they have these big columns. Column number 1, ASAP will appreciate this, effective disease prevention and health promotion. Building this system that looks at how do we keep people healthy. Column number 2 is effective health and healthcare systems. And notice that they've broken those out. Health care does not necessarily equate to health. In fact, most studies show that only 20% of an individual's health is based on their health care. It's based on where they live, what they have access to, their economic status, their ability to access transportation, and all of those social determinants of health are part of the broader system that we need to look at creating. The next one is funding models that drive a change in the decision-making process, that get us to where we want to go. And there's a lot of experimentation in the U.S. around that. We need to leverage these new technologies, incredible stuff coming out, whether it's wearables, big data, machine learning, genomics, precision medicine. All of these are going to radically change what we know about an individual and how we can create a better system. We need to develop, align, and support the human resources. And finally, we need a strategic alignment in the determinants of health, these social issues that create or keep from creating health. So let me talk about health sustainability and financial sustainability. This is the one equation we have. It's not Einstein for sure. Value equals quality over payment. What are we getting for our service out of what we pay for it? And so we're looking at this and saying to ourselves, this is sort of what's driving the system in the United States. How do we create this value in our system? And that's been the talk now for a couple of years. We don't want to just pay. What do we get out of that system at the end? What value does it create? So what we've done is our initial focus on the supply side, on doctors and hospitals, and the whole healthcare system, is begin to change how we pay for this. Initially, we paid under a fee-for-service system here on the far left. So that increases volume, increases length of stay, increases ancillary testing, because people get paid for each quantity of service they deliver. Move to DRGs and Medicare. You still get paid for volume. The more admissions you get, the more you get paid, but you get less. Obviously, you're driving down length of stay because you want them to stay a shorter period, and it drives down all of the other services that are done. And finally, we're moving now to what we call accountable care, which is part of the triple aim, which is if you pay for these outcomes and we try to reduce per capita costs, we'll lower volume, we'll lower length of stay, and we lower the ancillary testing. And that's this whole shift to value-based payment models. And as part of the triple aim, we want to improve the experience of the patient's care, we want to implement population health, and we want to reduce the total cost of care. It's a big mission. And big missions don't happen by saying we're going to do a big mission. They happen by creating small pieces and putting those pieces of the puzzle in place. The Robert Wood Johnson Foundation said around this whole sustainability issue, we want healthcare that is affordable. We want patients who are informed, understand what they need to do, and are empowered to make the right decisions. We want to have care that is based on the evidence. We want people to practice based on what we know works best and not just willy-nilly do whatever they think needs to be done. The system itself has to be accountable for its cost and resource use. The doctors and hospitals need to be held accountable. We need an environment that fosters a culture of innovation and improvement, and it has continuous learning. And we want to innovate and evaluate this innovation and say, yes, that is effective, or no, that innovation is not effective, and let's not use it. So no longer just take everything we can and throw it at the problem, but take things that we know have proven results and are based on the evidence. And we want to have reliable information that we can use to monitor this system. And information is critical to all of it. And I know here in Brazil there are some issues around data and getting that information. And in the United States, we're still working on pulling all that information together and more of it to make smart decisions. But that's a critical piece of this. So to move this to value, how do you move this system to value? You transform the current payment system. And we're doing that, moving away from fee-for-service to bundled payment, capitated payment, outcomes-based payment, etc. You want to pay for care that is proven to work and not pay for care that is not. We need to incentivize the consumer, incentivize the patient, get them to begin to reap the rewards and potentially reap the negatives of not doing the right thing, of not taking care of himself, but in an appropriate manner. But at the end of the day, if I as a patient don't have any skin in the game, or get any benefit, or have any negative repercussions, I'm less likely to do the right thing. And we need to improve and shore up our healthcare infrastructure in the United States, just as everywhere else. And finally, and this is very important, if we want to create systems that are sustainable, we need to bring the public and private sector together. We need to create a broader look at health and healthcare in our systems. So what is the role of government in creating a sustainable healthcare system? First, ensure adequate funding for the elderly. We need to have money for those, and I know the elderly population here is growing rapidly, and I remember seeing 2 years ago here, I think it was, someone from the government presented the numbers on 20 years from now or 2050, it was huge. In the United States, we face that issue too. Government needs to make sure that the healthcare professional needs of the country are met, that we have an adequate number of doctors or nurses or physical therapists or respiratory therapists to do the healthcare work that we need to get done. Prevention. Government's role is to help create an environment of prevention. Put in place those things that can get us to focus on that and work on those broader issues. Government needs to look at creating an environment that fosters innovation. And finally, a role in reducing costs by demanding that the system provide value. So, what are some of the sustainable health systems we have in the United States? Dartmouth-Hitchcock has put this out, and this is their mission now. We believe the focus of organizations such as ours should no longer be on just treating illness. We have an obligation to ensure health. That's much broader than care. And how do they go about doing this? This is part of their campaign. Imagine a sustainable health system with one goal: to improve the lives of the people and communities we serve for generations to come. Imagine a health system that focuses on health and not just health care. Imagine a health system where care is based on value and not on volume. Imagine a health system grounded in population-based strategies and not market share. Imagine a health system that rewards quality and not the quantity of procedures. Imagine a health system where patients, when well informed, receive only the care they want and need. And finally, this is what they are trying to create now. They're on that road to creating a broader value-based system. They have created as part of this what they call the high-value healthcare collaborative. Again, this idea of working together, cutting down the silos and saying, how do we come together to solve these problems? So they brought together the Dartmouth Institute, Dartmouth-Hitchcock, Denver Health, Intermountain Healthcare, and the Mayo Clinics. And these were the initial founders. And what they are doing is taking specific problems, pulling all of their information together, and collaboratively trying to say who does it better, or what can we learn from them? How can we share that expertise around the system? How can we create this system that becomes sustainable? So back to this concept that I just mentioned a little earlier. Successful innovations often target a specific healthcare challenge amongst the population. You're not just going to wake up one day and have a sustainable healthcare system. It's going to be built by putting together these small pieces in your area. And so these are the pieces that they're focusing on. Knee arthritis, hip arthritis, back pain, diabetes, heart disease, asthma, obesity, depression, and perinatal care. And they picked these initially to start and say, how do we create this value around these areas? And this is some of the little detail of what they're doing. So in the areas of heart failure, diabetes, hip and knee and spine, they're implementing a patient-reported measures across all of those, across all of the institutions. And then, again, comparing the data. In those 4 areas, they're looking at shared decision-making. How do they work with the patients to make shared decisions around those, around diabetes or a hip and knee replacement? They're looking at patient engagement. How do we do patient engagement in these, and who is better at patient engagement, and what can we learn from them to take to our other facilities and see that our diabetics are looking at their feet every day, or getting their annual eye exam, or measuring their blood glucose, or getting a hemoglobin A1C. In the areas of depression, heart disease and diabetes, they're doing depression screenings. We recognize that issues like mental health, and they particularly recognize this, have a major role on outcomes, health, your health status. and has not been focused on a lot in the United States. So they're looking specifically at screening and treatment for diabetes and heart failure. Then they look at some technology. How about a little remote patient monitoring for diabetes and heart failure? Can we do some in-home monitoring? Can we keep people out of the hospital? Maybe even keep them out of the physician's office completely, because we're getting everything through telemonitoring. How do we use that to lower the price, improve the quality, and keep our people healthy? And then they're doing complex patient management, and finally in sepsis they're doing bundled measures. And so they picked select areas to focus to then begin to build a bigger system. So let me talk a little bit about sustainable healthcare. It needs to have a long-term strategic perspective. It needs to focus on disease and prevention, quality, the institutionalization of environmental concerns, and accountability and individual responsibility. In 3 years ago, David Nash and I co-authored a piece called An Accountable Health Organization, because in the United States, accountable care organizations are the big thing, but they're focused on care. So we put together a broader construct that says, yes, we need the healthcare system in this, and just like an accountable care organization has governance and leadership, we need an organization that includes healthcare, government, not-for-profits, community service organizations, schools, and that comes together to look at the health in the community and allocate resources. These are some of the broader initiatives in the United States. Healthways has their blue zones, and these are efforts to create broader communities of health. The Clinton Health Matters Initiative has their community programs. There's one of them in Jacksonville where I live. And then Esther Dyson, a leading healthcare innovator and investor, formed the Way to Wellville, and she has 5 communities that are trying to create health. The question with many of these is, how do they sustain themselves? Ultimately, where does the funding come from to keep that going? And so there needs to be this integration and say, we're using dollars over here, maybe we need to pull them into some of these initiatives. So to move to a sustainable system, we need government and the private sector together, each having a role to play. We need the providers, the doctors and hospitals in the system, and they need to start by looking at discrete services. You don't eat the elephant in one bite, you start. And that's what we need to do with this. And we need to look at new models of care delivery, technology, allowing accessibility with that, using technology to reduce costs, making sure that services are at the right place in the right time, allowing people to practice at the top of their license. So if a nurse can do something, let them do that versus the doctor. Use the top of somebody's license to control costs. We need to look at the payment structure, move to value-based payments, create an integrated system, measure the results, and have patients and families in this process. They are in the shared decision-making and become a formal part of the process of creating sustainability. And finally, the information needs to be available to everybody. We all need to see it and understand what's going on. So I'm going to close with this slide. People see this slide and they think, wow, look at that lazy American, right? Unbelievable. They drive their car and walk their dog. But I use this slide for 3 years now. For the first 2 years, I didn't understand the slide. I laughed at the lazy American. Look at the slide again. Do you see any sidewalks? Maybe they have a bad angle and can't walk. Maybe it's not a safe neighborhood and they don't want to get out of their car. So when you think about health and healthcare, look very broadly. The answers are sometimes outside where you think they are. So with that, I will close and thank you all very much.
Congratulations. Parabéns, Fred. Eu, como seu amigo, tenho que lhe aconselhar uma coisa. Não use a camiseta do São Paulo que aquele rapaz lhe deu, junto com essas meias aqui em São Paulo. Não use. Tome cuidado com isso.